Hello and welcome to the next Complete Physio podcast episode. I'm here today with Mr. Roland Walker. My name's Chris Myers and I'll be your host. And today we're going to be talking about Achilles ruptures. Now, Roland, you see an awful lot of Achilles ruptures in both your NHS and private practice. And what I want to talk to you about, as we were talking about earlier, is we see loads of Achilles ruptures and some of them go down the conservative treatment, which is where they go into a boot and then we rehab them after they've been in the boot. But we're not going to talk about that today. We're going to talk about, you're a surgeon, so we're going to talk about surgery. And this is a bit of a personal interest of mine, is I want to try to get to the bottom of why some people do really well after Achilles rupture surgery and why some people don't do quite so well. So we're going to go into that. We may have the answers, we may not, but we're going to give that a go today. And we're talking specifically, just so people know, about the mid portion of the Achilles. So we're not talking about the insertion where you can pull the tendon off the bone. We're talking about that middle bit of the Achilles. So Roland, do you want to just give us a bit of a background of who you end up doing surgery on for mid portion Achilles ruptures?
Yeah, well, thanks for the introduction. Mid-portion Achilles ruptures, usually a sports injury.
Yeah.
So 80 to 90% of the people that we're seeing have had some kind of athletic injury. So they are a slightly younger population. There is a cohort of more elderly patients who rupture their Achilles, and their background is more of a sort of a degenerative tendinopathy. But they are a slightly different cohort and perhaps have a different management. So I think just to sort of narrow it down, we're really talking about athletic people, sort of mid-20s through to early 50s, participating in sports. Some people have had some sort of prodromal pain, and some people it's a one-off kind of explosive injury. And it is quite an explosive injury. If you talk to people about their history, I mean, one of the classics is I was playing football and someone chopped me down from behind. Yeah. I turned around and there was no one there, but it felt like a kick. And sometimes people actually say they hear a bang or a crack. There's actually so much tension.
Yeah. I've actually been in a room in athletics where somebody ruptured their Achilles, and I was on the other side of a hall. And I heard it, and I had no idea what it was, and then saw the person after, and I was like, "Wow, that's like the noise of a rupture." It's
like a starting gun.
Yeah, exactly that. It is like that.
Or a bit of rigging on a yacht. Breaking under tension or something like that. So. I mean, it gives some indication. I mean, this is one of the biggest tendons in our bodies. Has some of the highest loads. Yeah.
And it's the force that it's under to make that noise.
So it gives some indication of the kind of energy that's involved in rupturing your Achilles.
Yeah. It's probably why it's so difficult and so long to get people back as well, because it's got to get back to being able to do that same load again and take that force.
Yeah, completely. I think that almost one of the first things I say to somebody when they've ruptured your Achilles is ruptured their Achilles, 9 to 12 months, really out of, good level sporting activity. If anyone beats that, then they're doing really well, in my opinion. You guys probably know more.
I mean, 6 months would be the earliest, and that's sort of why I wanted to do this podcast, because I see people like 3 months post-surgery, they're doing a single leg heel raise. And I see people 9 months post-surgery, and they can't do a single leg heel raise. So let's go back. So let's say you see a patient in clinic. How would you ascertain? Let's say they are quite athletic. They want to get back to a certain level of activity, which is obviously one of the criteria you may look at. How do you make that decision as to whether somebody should have surgery or not?
Yeah, it's a really good question. I mean, it is actually, despite all our modern imaging techniques, MRI, ultrasound, it is basically a clinical decision. So my initial management for someone with an Achilles rupture is to put them into an equinus cast. I try and go maximum equinus.
Yeah, so equinus being where that you point to the ballet ballet position.
So tend to run the slab along the front of the ankle, and it goes about sort of halfway around, and then you wrap the rest up with bandaging. And what you're trying to do, where the two parts are separated, and we can come on to whether it's two parts. And,
we'll come on to that.
You're really trying to put those two ends as close together as possible.
So you point your toe, the two ends should come together.
Correct.
You don't really check at that point, I assume. You would just...
No, I mean, you would examine the patient clinically. You will often feel the defect, the gap in the tendon. That tendon is usually under so much tension that you can feel it. So when the tension goes out of it, you feel a defect. You can squeeze the calf and see that there's no sort of flexion, plantar flexion of the ankle.
So that's the sort of Thompson test,
and the most important way to examine these patients is always examine them prone, so lying on their front. I tend to put the knees together, the ankles together, flex to knees to 90, and then just you can check the angle of dangle. You can check the resting position of the foot. So you're looking for are the 2 feet perfectly aligned, or is one dropped kind of right down?
And that would indicate that you've lost the tension
Correct.
in the Achilles, and so the foot sort of just flops down, doesn't it?
So often, I often don't have the luxury of seeing patients day one.
Yeah.
It would be great if I could, but those patients are usually being looked after in emergency departments and so on. But that's what I would do, and what I would do with those patients, put them in an Aquinas slab, and then personally I try.
So at that point, they've got the slab on, they've got 2 crutches, and they're basically just non-weight bearing. They're hopping around,
Correct.
aren't they, for a couple of weeks?
Yeah, I mean, it's worth saying at that point, the studies tend to suggest this injury has quite a high risk of deep vein thrombosis, which means a blood clot within the veins.
Yeah.
Because the calf pump is responsible for sort of circulating the blood from the lower extremity back up towards your heart. When that pump is not working, blood can pool and you can get blood clots. So, I'm very keen that patients have some kind of blood thinner.
Would they be put on that, if they go to A&E and get put in a back, they should be put on, is it a Pixaban, or what would they use normally?
To be honest, it probably doesn't matter what agent. Some people, in the US, they just use aspirin very liberally.
Right.
In the UK, we tend to use the low molecular weight heparins. Now that means self-injecting once a day, which is quite a big thing for people to do. But nevertheless, that seems to be what most hematology departments and what most guidelines have. Then you've got the oral anticoagulants now. The only downside of those is that they don't have a reversal agent, and you need a period of time off them before you're going to go ahead.
Do you want to just explain what that means?
Yeah, so they're quite weak blood thinners, but nevertheless, the way that they work is they kind of bind, permanently to some of the factors that are involved in the coagulation cascade, and whereas these injectable agents, there is a sort of antidote or a reversal agent.
For before operations.
Or if someone were to have a bleed. With the these, they're called DOACs, direct oral anticoagulants. They tend to be irreversible. And so it's not ideal to have pre-operative patients on those. You might need 48 or 72 hours run-off time before you then do a surgery. So the injections do work, and injections are probably the thing that most UK patients are going to be put on. So coming back to the sort of more orthopedic management.
So you put them in the black slab for a couple of weeks, is that right? A week, and then they come back to clinic?
Yeah, I tend to put the patient in an Aquinas slab in this slab, and then get some imaging. Now the kind of imaging that you get will depend where you work. We're very lucky, both in my NHS and private practice, to have ready access to MRI, and I much prefer MRI in the sort of Aquinas position, because that really shows me the resting position. It's the sort of post-reduction position of the tendon.
And at that point, what are you looking for on MRI to reassure you or tell you need to do surgery? What are does that help you make the decision?
Yeah, it does. To an extent, it does. So it will show you the location of the rupture. Okay, very high ruptures that are almost going into the muscular portion those tend to have a slightly better prognosis with non-surgical management. The muscle is very well vascularized, so they tend to heal better.
Yeah. So that's where it's starting to go up into the leg, where the muscle meets the tendon.
Right.
Yeah.
And actually, those technically those are quite difficult to repair because you might
it's like rump steak, isn't it? At that point,
absolutely. You're trying to suture sort of tendon tissue into muscle tissue, and muscle doesn't take a stitch very effectively.
Yeah.
So you're looking for a sort of typical mid-portion rupture. Likewise, we're not really focusing on distal ruptures, but occasionally the tendon actually pulls off the bone distally.
Certainly in older patients.
Yeah, and that is a very different
okay.
injury and needs a different surgical approach. So level of rupture, and there's this thing around gap.
Well, I want to get on to gap because we will often get emails saying, I've had an ultrasound scan and it's 1 centimetre or it's 1.1 centimetres. I've been told I need surgery if it's and it's to a certain extent it's a load of rubbish, the gap, isn't it? But do you want to just talk through it?
So there's been this idea of, what is the gap? And when I started in orthopedics, many moons ago now, we were repairing a lot of Achilles tendon. And then there was this sort of wave of studies came out probably 10, 12 years ago
and
now.
Big studies, weren't they?
Big studies showing that actually if the gap, if the separation between the two ends of the tendon is fairly small, probably less than 1 centimetre or so, that patients would do equally well with or without surgery. And they were very compelling papers. They seemed to be well performed, well randomized, and giving quite a powerful message that we are, potentially operating on too many patients.
Yeah.
The reality of a tendon, if you've ever opened and seen a ruptured Achilles tendon, it is very rarely a kind of neat transverse tear that gives you.
Yeah. But people are picturing a twig that's snapped.
Yeah.
And it's just not that, is it?
No, it's not.
Do you have an analogy of how you describe it? I actually think it's a really hard...
Yeah, I mean, sometimes it's like a ball of spaghetti, There are literally strands and fibres
everywhere,
going in every direction. Yeah. I've seen Z-shaped ruptures. I've seen sort of delaminations where the sort of superficial layer has separated from the deep layer. And actually, if you look on scan, because the tendon has slid like that, can almost give the impression that the tendon's still together.
But it's still elongated. It's still lost its tension. Yeah.
So the morphology, the actual shape of the rupture is hugely variable.
Yeah.
And that gives, that's one of the reasons that personally I like to look at an MRI scan rather than an ultrasound, because with ultrasound we're relying very much on what the radiologist is telling us. That's number one. Number two, to do an ultrasound, you have to take the cast off to access it. Yeah. And there's a potential, you might be scanning at 8 or 9 days post-injury. You might just be starting to get some initial tendon healing. And then
they come along.
They come out of cast, the ankle starts moving, and do you actually pull apart your initial kind of blood clot and all that kind of good quality?
Because I do a lot of scanning, as you know, and so the first thing is when your foot is fully plantar flexed, it's actually hard to get good contact with the ultrasound. So you can use a load of gel, but you really to do it, you've got to bring the foot into a bit of dorsiflexion for it to do it. That's why we would only scan further down the line, but I can understand why that's a problem. We're going to come back to it, but the fact that you've described all these different types of tears is interesting to me, because maybe that is one of the factors in why people do well, and then whether or not that changes your surgical technique. But we'll come on to that. But let's keep going with it. So you'd look for an MRI. You've talked about the gap. So I think you were going somewhere on that in terms of what you're looking for.
Gap, I mean, we sort of started to obsess about the gap around sort of 7 or 8 years ago, I think, and we started to really think, okay, gap's really important, and starting to really make surgical decisions based on gap. If the gap was very small, right into a Vacaped type boot, and you go down a functional rehab with some weight bearing, maybe from 2 weeks or 4 weeks.
Yeah.
And then the foot is in this down position and gradually gets kind of brought up over maybe a 10-week period.
Yeah.
Actually, that rehab is the same if you've had
Yeah.
an operation. So I think that's an important message, actually, that rehab doesn't really change with or without surgery. It's pretty much the same.
Yeah. No, and I agree, but there's always a but, isn't there? There is a tendency that with some of the surgical ones that seem to go really smoothly,
you can push.
Is that you can push a little bit more. They see, this is only when it all goes well, and we'll go on to the pros and cons, and potentially you can get that sort of peak force up, and there is some evidence to say that at 6 months you've actually got more strength surgically. However, you've got to weigh that up with the risk of surgery, infection, which we'll get onto. But
So back to the gap. So that became, and probably still in many units, is a decider. You know, the radiologist writes a report and says there's a 1.3 centimetre gap, and that might then go into your non-operative, route, or a 2.2 centimetre gap. Okay, that's too big. Yeah. And that patient then needs surgery. Yeah. In reality, I think the difference in reporting of gaps just between different radiologists or different orthopedic surgeons or different physios will be massive. If you got,
I mean, it's even bigger than massive. Yeah. It's like they're looking at, people are writing reports, but looking at two different reports, but images, but they're not. Yeah. They're looking at the same image, and you can get two very different measurements.
So really, for me, the value of the scan is to confirm, is it ruptured or not? You know, and I have once opened an Achilles tendon where a consultant, when I was a trainee, and a consultant had diagnosed Achilles rupture without any imaging, without a scan, and said, Roland, could you repair this lady's Achilles tendon? So I think the real value of scanning is to determine whether or not the tendon is ruptured. Yeah. I've had one case some years ago as a trainee where my consultant at the time had examined a patient, decided clinically that the tendon was ruptured, said, Roland, could you repair this lady's Achilles tendon? And got her prepped and draped, made an incision, and a pristine normal Achilles was looking at me. And it was one of the most heart in mouth sort of
you don't forget those
experiences. And the lady was fine, but it was a real kind of wake-up call.
Where do you think that error can be made other than just human error? Because for me, if it's ruptured, a clinical assessment is 90. I suppose that's the 99.9%.
And that lady was, the consultant was a very well-known foot and ankle surgeon, very experienced, and essentially she had a muscular, she had a muscular tear.
Musculotendinous tear?
No, even a more proximal muscular tear. Okay. She had a quite a significant tear, so she had some loss in tension.
I was going to say, because you can, in theory, an empty junction tear, definitely, but you'd probably have seen that, wouldn't you? But further up, you can still, it's the same structure, isn't it?
So I never want to be in that situation again, and I now, I train fellows and registrars, and I say to my trainees, always get a scan before you put knife to skin, before you operate on someone, because you just have to know for sure. So actually the main reason for imaging is now for me not so much to assess gap size.
It's confirmation.
It's confirmation. There's a couple of nice things you can see on MRI. MRI shows the fat really well, and there's the deep too. So on the underside of the Achilles tendon, there's quite a bit of fat, and sometimes the fat can kind of prolapse up into the gap. And if you see fat interposition, so fat between the tendon ends, that's a sort of relative indication to operate for me, because the fat may kind of get in the way and
stop
block
those two ends.
And block tendon healing. And you see that beautifully on MRI. So that's really good. You can pick up some of these subtle morphology changes. And I did an Achilles recently where you could see that there was this long sort of tongue flap that had sort of folded over on itself. And actually when I opened the tendon sheath, it was exactly, as it had appeared.
So it gives you a bit of prep before you go in. Just playing devil's advocate on the MRI from a bias ultrasonographer. if you've got a gap, but you've already said the gap isn't everything, and I agree. But if you've got a gap on MRI, what we used to talk about in ultrasound, and on occasion it can be useful, is to put them into full plantar flexion to see if the ends, so it's a dynamic ultrasound to see whether the ends come together. Do you think there's any value in that, other than maybe a bit of reassurance for conservative treatment?
Yeah, I think, I did get an ultrasound for one of my Achilles patients recently who is going down a conservative route, but we wanted to check that the tendon ends were healing and moving in continuity, because there did seem to be a sort of dip in the tendon, and there was therefore a worry, okay, is it stretching out? Is it separating? And that scan was more like 4 weeks down the line.
So around that 4 to 5 weeks, you might be happy to do, because you've got to move the foot a bit to do it, don't you?
And that's great, because then if you see that the tendon is moving with the muscle unit and that they're all moving together, brilliant. You can tell that that the thing's joining back up again. You're getting some healing taking place between the two ends of the tendon. So I think it's got a real value if you're maybe 2 weeks out and you're thinking of going down a conservative route. I think there's dynamic ultrasound at that point. And actually, if when you come to repair an Achilles tendon, even at 2 weeks, it can be quite remarkable how much healing has taken place, particularly in a sort of young, fit, athletic patient. So 2 weeks you can open the Achilles, and there almost looks to be a kind of tube-like structure, and essentially the sort of blood clot from the rupture has solidified and sort of congealed around the tendon ends, and you actually 2.5 weeks, you're actually having to break that down and kind of separate it and free it all up.
Do you think that's normal healing though?
Yeah, I think
that's how it heals.
That is normal healing. But these are patients when we're operating who are usually elongated, so that there's usually we're usually operating if the tendon ends are too far apart. And the best, coming back to clinical assessment, the best way to assess whether the tendon ends are too far apart is to allow a couple of weeks of healing to take place, and then to re-examine the patient with them prone.
So you take off the back slab and then that's interesting.
And then re-examine, and if the angle of the feet is perfect and it matches the other side, if there's no big palpable dip and gap, then you'll feel more confident to go with a conservative route. And if there's clearly asymmetry and a palpable defect at that point, then it's decision made. You need to go for an operation.
But also at the same time, if you've got a patient that says, Roland, I appreciate what you're saying, we could go conservatively, but I want an operation. There's a massive patient preference here, isn't there?
Huge patient preference. I think a lot of people just intuitively know what they want to be done. And I think, that's fine. I think you obviously have to inform the patient and give them all the kind of pros and cons. But you're right, some people have just made up their minds. And I think patient choice is really important. If an athletic person says to me, I want to have my Achilles repaired, they have imaging that shows a mid-substance rupture, absolutely no problem. I would just go ahead.
It's an indication in itself.
It's an indication, and I think there are advantages. I think there's plenty of data, plenty of evidence that show that return to sports, rehab, power. There is a little bit of difference in power between surgically treated and non-surgically treated. There's something that you can probably explain to me, which is a hop counter hop test. And I think patients who've had surgery perform better in those kind of objective studies of explosive performance.
I think there's almost, put it this way, if you're an elite footballer or whatever, you're going to have an operation, aren't you? So there's almost a slightly more guaranteed route, if that makes sense, with the operation, because you're getting some stability and some strength in that tendon straight away, aren't you? But then you've got to weigh it up with the downsides, obviously, of an operation, and
Certainly.
the first thing that comes to mind is wound infections. And there's lots of quite public football cases actually of where massive wound infections have happened.
Corzola had that horrendous wound breakdown. He was an Arsenal player at the time. There's quite amazing photographs because he ended up having something called a radial forearm flap. So it's one of the thinnest, most low profile free flaps that the plastic surgeons can do. So they actually transfer tissue from his arm, which had a tattoo on it,
of his son
down onto Achilles. Unbelievable.
Kevin Peterson, he wrote in his book about having a really bad infection after his Achilles. And they do normally clear up, but it can be a nightmare, can't it?
They are an absolute disaster.
What is it, just a dirty pit of the leg? Why do we get infections there?
So why do we get infections? I mean, that's the $1 million question. I mean,
and it's also the surgeon's worst nightmare, isn't it?
It is the surgeon's worst nightmare. I mean, it's fair to say that the infection rate is really, really low.
Is it coming down?
Yeah. It is. I mean, I looked at one of the big kind of studies, and it had an infection rate for open surgery of 0.5%, so 1 in 200, for a serious infection. So that's, that is a really low rate. And actually, if you think we should be operating on essentially fit, healthy, athletic people, so they should have very good wound healing potential, very low risks of.
And that's actually a reason maybe not to do it in the older individual if they don't have that excellent
or to do
potential.
some different technique, or treat in a different way.
Exactly. So you got your patient in there. They're at 2 weeks is when you're saying you're probably going to make that decision, or is that when?
So I think if I see someone acutely, then it's Aquinas cast, get some imaging, anticoagulate, and then it's a follow up as soon as possible after the imaging, and then a discussion of the pros and cons of acute surgery versus not having surgery. And someone may decide right there and then, okay, I want to, have the quickest possible rehab. I want to maximise my post-injury strength. My sports are really important to me.
And that's important, which sports you play, isn't it? If you play golf, you don't really need your Achilles, but if you're going to be a basketball or netball, we see a lot of netball players, footballers, if you want to get back to that sort of level of sport, I always say to people, if you want to get back to that level of sport, then you need to consider surgery. It doesn't mean you need it, but you should think about the pros and cons.
And so then a portion of those patients will just decide to have surgery there and then. If someone decides, okay, I'm going to go maybe consider non-operative surgery, I'll then see them at 2 weeks and reassess. If they've lost tension already at 2 weeks, then we convert to surgery then. And then the ones who choose to go non-operative actually need to follow up a bit more carefully, because there are a small but significant group of those patients who stretch out. So whose healing tissue just elongates in that.
And this is the big fear, really, whether for conservative, but even post-surgically, it's that less of a risk post-surgical, but this elongation. And it's the elastic band analogy, isn't it? If you pull an elastic band and you let go and it pings back, that's a really good Achilles, isn't it? But if you just go past that sort of plastic bit and you ping back and it's a bit of a baggy elastic band, it's going to be very hard to produce the force, isn't it?
I mean, genuinely, some of the most challenging cases to manage for me have been patients who've chosen to go non-operative and who've then stretched out. And then you're operating at 10 to 12 weeks sometimes, maybe even later. And you're already then getting into reconstructive options,
as in like FHL tendon transfers. Which is a different
and that
ball
poor
game,
patient has already done 3 months of rehab, and then they're back to square one having an operation at 3 months. And I've been through that with a few of my patients, and that's almost harder to manage, sort of emotionally, psychologically, than having a wound infection post-operatively. It really is challenging, and it kind of pushes the sort of the end of the.
I saw one today.
Way down.
I saw one today.
Way down.
Misdiagnosis last January. Didn't get it diagnosed. This is 23. February got diagnosed because it went again, but it had gone. put into a boot, but it was too late. The elongation had happened, and he's now thinking about an FHL transfer.
Yeah.
And it's, it's a good operation. It's not a great operation, isn't it? It doesn't suddenly bring back your calf, but it can.
No, I mean, it's a good operation. I've got a police officer back to being able to do their bleep test and so on after, with those kind of procedures. So, you can get someone back to a reasonable level of function, but, those patients are probably, they get a lot of atrophy in the calf. So a lot of calf muscle wasting in that 3 months, that initial 3 months, and then they've got to go through another kind of 3 months. So, being able to rebuild calf strength
takes a long time.
After 6 months is really
particularly
hard.
with not a great, not a tendon that's got that real tension. So with regards to the patient that you've decided to do surgery on, do you want to just talk through, and I'm really interested in what you do in surgery, because, and whether that changes according to what you see technique-wise?
Yeah, I mean, it's funny, like a lot of surgeons, I've been a bit around the houses, and I now do what I was sort of doing first taught in 2009. When I started as an orthopedic registrar. So it is funny that the flat spiral of progress. So I think if we talk about the sort of most straightforward Achilles tendon repair. Probably the one thing that's changed is the patient positioning. We used to put patients fully prone, so that means lying on their front. And there's quite a lot of, from an anaesthetic perspective, there's quite a lot of stuff that you have to do to protect patient's face, their sort of pressure areas and stuff. You need special kind of a mask with a sort of jelly in that fits the patient's face. You have to manage kind of brachial plexus, shoulder positioning and so on. So actually there's quite a lot of challenge in positioning a patient like that for an Achilles surgery. And what we tend to do actually is put people in the recovery position. And if you put a patient in the recovery position and they internally rotate their hip, you'll actually get almost like a perfect access to the lower leg at the back.
So you're operating on the lower leg?
Correct.
So lying on your left, it will be their left Achilles.
So we say bad side down. And that's now become that's been published by the Guildford group. And that is now the sort of gold standard for hindfoot surgery. So for hindfoot arthroscopy, for fixing posterior malleolus fractures, for doing all the Achilles surgery. And that you've got about 2 hours or so of safety in that position.
What becomes unsafe about it?
So if you imagine it's a patient sort of lying like this, and you've probably everyone's experienced it. Your
arm goes numb.
Yeah, you wake up. You wake up in the night. You've been lying on your shoulder, and your lower arm
Saturday
goes
night
completely numb. And if you're in your own bed, you kind of
move naturally.
Subconsciously, you would realise that your arm's feeling a bit weird, and you roll over, and it's like completely floppy and dead, and then it comes back to life, and it's quite painful as it's coming back to life and so on. Obviously our anaesthetised patients can't do that.
No.
So I've had one patient who had a slightly longer operation who did get a bit of a brachial plexus issue. It resolved within 24 hours.
So that's quick.
It was completely better in 24 hours.
They were probably a little bit scared for a while.
But it's scary, so I've sort of had this rule now that if we're going to use that position, we need to be confident when we start any operation that's going to be done within a couple of hours. And if we think it's going to be longer, then we should go for the sort of formal prone position. Now, the one advantage of a sort of formal prone position is you've then got both legs in the same position. So again, when I started, what we used to do is actually prep and drape both legs. And so you've got the uninjured leg on one side and the injured leg on the other. And what that means is you can judge tension. So you can repair your tendon. And when you think you've got your great repair, you can do the exact clinical test that I've been talking about all this time. Now, with the lazy lateral position, you can't. You can't do that. And so what you have to do is examine your patient pre-op. Once they're off to sleep, but before they're positioned, and get a feel for what is the correct tension for that patient.
Because the tension is really important, isn't it? Because if we're talking about the elastic band, if you don't tension it tight enough, so toes pointed down, that tight position, then there is that potential afterwards where maybe it's still slightly elongated, and therefore maybe that's one of the reasons that we see that some people are slower than others to get their calf raised.
Completely.
I mean, it sort of has to be, doesn't it?
Yeah, I mean, elongated tendon leads to a loss of power. You know, ultimately, the only reason we're doing Achilles repair is to create tension in the tendon, in the muscle. You know, and so anything long is going to lead to weakness and loss of performance, loss of push or strength.
But anything too tight?
Anything too tight is then tough to rehab. You know, you have patients with a very kind of stiff ankle and difficulty regaining dorsiflexion. But,
so
you guys are very, very good at working through that problem.
Well, I would always rather, I feel as physios, we could get something looser.
Yeah.
We can never, ever change elongation.
Correct.
You just can't reverse it. You can compensate, okay, but you can't reverse it. So basically you're in, and this is what I'm picturing. I've seen a few Achilles repairs, and there's an art. I don't know, is the tension a science or an art? It feels like it could easily be an art. Yeah.
It's completely an art. There are very rarely a tendon rupture that gives you like a fracture, for example, where you've got a good read. You can see where one part really interfaces with another.
Bones are so much easier, aren't they?
Yeah. Tendon rupture doesn't have that neatness to it. You know, as I said, we've already described how you can hear like a gun going off.
Yeah.
You know, the amount of damage
just sort of does that, just
and the
goes
whole
off.
thing just it explodes. So it is a bit of an art.
So talk us through how you do it. So they're lying down.
So recovery
what
position.
sort of incision? We're going to talk about the different types in a minute, but I know that you and a lot of people will use what we call an open technique.
So I use a dead straight incision, absolutely centered on the rupture.
Yeah.
Okay, so it's about a 6 centimeter incision. Sometimes needs to be a little bit longer, but I center it dead center. You do see a lot of people putting the incision on the medial side, and the reason they do that is there's a nerve called the sural nerve running on the lateral side. So people are anxious about nerve injury, understandably, and tend to go to the medial side. The problem with the medial side is blood supply. So there's this concept of angiosomes, and what this essentially means, there are paddles of skin that are supplied by a single sort of small perforating artery that comes up to the surface and then spreads out on the surface and will supply a kind of paddle of skin.
Yeah.
And all of our different bits of skin have these kind of main perforating arteries. And if you look at the angiosomes at the back of the ankle, where the two angiosomes meet is actually along the lateral edge of the Achilles. And that was shown very nicely by Roger Atkins in Bristol, who did a lot of work around calcaneal fractures and actually devised a flap based on that angiosome, which runs along the lateral edge of the Achilles and then along the sort of sole of the foot. And you can raise this quite large skin flap, but with good vascularity and good blood supply. If you go over to the medial side of the tendon, there is a risk that you're actually cutting through some of the arterioles that supply that central portion of skin. And it's interesting. I've only had to manage 2 or 3 really bad infections after Achilles surgery. The incisions for all 3 of those cases were on the medial side of the tendon. So I've actually tended to go right down the middle. I don't mind seeing sural nerve. It's a nerve I see all the time. Operate near. And it's a big nerve, it's easy to find, and you can easily mobilize it and move it out of the way. So I really don't worry about sural nerve injury. If you touch a superficial nerve, they can get a bit sensitive. So, I suppose I trade the potential for a bit of sural nerve irritability and sensitivity that is always temporary.
With the healing.
Versus sort of wound healing. But I'd almost rather see the nerve and protect it rather than risk going through it. So midline incision, and try and keep the skin flaps relatively thick so they're well vascularized and they heal well. You then see paratenon, which is the covering the layer around the tendon.
Like a sock, isn't it?
Yeah,
Around
and sometimes it's ruptured. Sometimes the force of the tendon rupture
how
is so
often does
big.
that happen?
Yeah, quite a lot.
Yeah.
The paratenon has been ripped as part of the repair. But when you enter the paratenon, you sort of enter almost like
you cut the paratenon.
Yeah. So cut the paratenon in line with the incision, and then you are in a sort of tunnel, and that paratenon wraps all the way around the tendon. And then it's a case of just working out, what's what, and that's usually, index finger, blunt dissection, just feeling for tendon ends, sort of removing the blood clot and hematoma, trying to free up the tendon, because particularly if you're operating a little later, everything gets all quite sort of stuck.
Is there
down.
an optimal time for operations? I was going to ask that earlier and I forgot.
Yeah, I think for most young, fit people, I would say the sooner the better.
Right, yeah. So within the first 1 to 2 weeks, ideally.
I think whilst the initial hematoma is liquid rather than healing and adhesions starting, it's just probably easier.
So you're in there, you're fishing around.
Yeah.
You're trying to feel for the gap? Because obviously, okay, not the gap, but you're feeling where there's fibres and where there's not.
Yeah, and you'll get a sense of what the shape of the rupture is and where the ends are.
Yeah.
Distal stump is usually quite easy to find, and then you need to sort of separate and mobilise that so that you can really get a good amount of suture material in.
Yeah.
And what we're doing is these kind of locking stitches. It's called a Krakow stitch. And
the Krakow stitch, because there's other types of stitches, isn't there? But that's the one that seems to be, it sort of seems like to be the classic way of doing it.
Yeah, so biomechanically, there are plenty of studies, mostly from the hand surgeons, but there's plenty of studies that show that a Krakow stitch has got the highest pull-out strength.
Right, okay.
And
so that's literally get two ends and...
Yeah, and hang a weight off it and see when the suture fails. And if you can get 3 locking stitches, it's quite good. If you get 4, it's quite another big increase in pull-out strength.
Right.
The 5th and the 6th don't add very much.
Right, okay.
So I sort of say again to my trainees, always try and get 3, locking stitches.
And what are they made of?
So that's a big thing, yeah. The suture choice, there are a whole range of stitch materials on the market. You can get braided sutures, which are a bit like a shoelace. So they're sort of a woven braided material. So they knot very, very well. They handle really nicely. They're very sort of intuitive to use. And so they're sort of nicer for the surgeon.
Yeah.
And then there are these monofilament sutures. So they're like fishing line, like a nylon sort of fishing line. So they're very kind of whippy and flexible.
Yeah.
And they have memory. They always try and flick back to their sort of the position that they're manufactured in. They're really annoying to use and difficult
so
to,
you prefer
to
the first
handle. But there is some evidence that these monofilament sutures are associated with slightly less infection.
Right, okay.
And certainly the braided sutures, if you use a non-absorbable braid suture. So sutures are also split into sort of a plastic material which will never biodegrade. It will just sit there in the healed tendon as kind of part of that healed unit.
Yeah.
Or you can get absorbable stitches, which are made of sort of organic, they're synthetic but organic materials that will basically your body's immune system can break down. And
that would happen over, say, a year?
Yeah, they all have a different duration where they're sort of strong for, and then they will break down. But most of the absorbable sutures will be pretty much fully absorbed by sort of 6 months.
6 months,
or so. Yeah. They certainly would have lost their sort of tensile strength by about sort of 3 months. So you've got absorbable and non-absorbable.
What do you use?
Do you know, I again, this is one of those things where I've gone round in circles. So I used to use something called a loop PDS, which is a monofilament that is absorbable, but quite slow to absorb.
Right, yeah.
It's what the general surgeons use to close tummies in laparotomy surgery. And I used that for many years, but it's difficult to knot and it doesn't handle very well. And I went over to the braided sutures, and then you see 1 or 2 infections. Interestingly, I hadn't had an infection in an Achilles, but I did have a gentleman who had a nasty infection in his quads. I had done a quads repair for him. And the problem is those braided sutures have pores and lots of fibers, and the bugs can just get in and hide in the braided component. And you can't clear that infection without removing all that suture material. So you're almost,
and that's hard, I can imagine, after
and that's committing
months.
The patient to another operation. So so I've gone full circle. So back to a PDS, which is an absorbable monofilament. It's a bit more of a hassle to use. It's not quite as nice to knot.
So you've done your Krakow.
So
you've got to try and get these two ends together and overlapping. How does that work?
So you put this so one suture in one end. With 4 locking.
If anybody's interested, you just have to go on YouTube, which I did, and just put Krakow suture, Achilles Rupture.
Krakow is in the city in Poland. And then you put your 4 loops in the other side. So you then end up with 4 strands. And this is where you actually need an assistant. You do need somebody to kind of help you with this, because what you then need to do is to knot the strands and then bring that bunch of tendon together. And you bring it together. You can put a clip or something on the suture and then kind of judge your tension.
As you pull it together, you're going to see their foot point, and then you have to make a decision on how much tightness.
Correct, and you're trying to get it to roughly where you think it's. You want to see visually the tendon ends opposed. You want to see the foot coming into a good sort of dorsiflex position. Somewhat matched to the other side, and perhaps just
into plantar flex.
Plantar flex position, and then perhaps
slightly tighter.
There is a sense that our repairs do just stretch a wee bit. So just
I think that they will stretch
slightly to over tightening. And then your assistant sort of then will have your suture clamped at that point, and then when you're happy, and then you do more throws to then.
And then you
to secure
put that back together, put the paratin on, do the...
we tend to do a second stitch, again with an absorbable suture, something called a silver skilled, which is like a lattice work stitch that you can do pretty much around the whole of the tendon. That's been shown to reinforce the tendon repair up to 40% of the strength of the core suture. So that's really worthwhile doing. You can do that with a very kind of small, fine stitch. So that's a second layer of stitching. And then again...
And would most surgeons do that second layer?
Yeah, I think so.
From your colleagues at Fortius.
I think so. I think it's pretty standard. You do this core stitch with the Krakow. That's the main kind of tension, and then you augment that with this peripheral stitch. I use a silver skilled technique, and it's really nice. You can sort of bring all the little bits
together,
together. And actually, I tend to try and tuck the ends of this very stiff monofilament stitch under one of my loops of silver skilled, so that I have the 2 ends very flat, so sort of flat down on the tendon, and not risking kind of poking through the wound or
into
irritating.
The paratin.
Irritating.
I've definitely seen that where I think we had a case where on ultrasound you could see I assume it was the nylon, or anyway, there were big white things on the ultrasound, and you could see, and you couldn't help but think that was irritating the paratin. So there's a technique around keeping everything quite central.
I want to keep, essentially what I'm trying to recreate is something that's really sort of smooth and tubular.
Sounds quite nice. I'd let you do mine.
That is then going to glide. And the gliding thing is important. So we try and repair paratin on it. That is variable in its success. The paratin on it is a very thin layer. It's quite friable. Sometimes in the central portion it's been torn. But you repair as much of it as you can. You want to.
What would you repair that with? Because
probably the same stitch. So something like a 2O vicryl, the same stitch that we
very thin.
That's something that's quite little. That absorbs relatively quickly. And again, is hopefully not going to cause too much scarring and adhesions.
Exactly. Because they can be a bit of a nightmare, can't they?
And then, detension the skin with a deep dermal stitch, again, a dissolving stitch. And then probably again, we all vacillate with all these different decisions, but I'm probably leaning back towards a non-absorbable suture for the skin closure.
So they'll come back 10 days later and you'll take it out?
Yeah, so that means come 2 weeks post.
Is that just because, from experience, sometimes it doesn't completely absorb and there's a little bit still there, or?
What I have found is there's a small cohort of patients who get a really kind of almost allergic or sort of inflammatory reaction to those absorbable stitches, because the stitch is being broken down by the patient's immune system. So it is creating an immune reaction.
So there is inflammation. Interesting.
And 2 weeks in an Aquinas, back into a slab.
Yeah. Non-weight bearing at that point. Obviously,
I tend to put a bit of tension on the repair. Actually, I don't tend to put them in the full kind of Aquinas position. I sort of tend to trust my repair a little bit, and just put a little bit of tension on the repair. I think that's probably healthy for it.
To try and stimulate some healing, because the idea of the sutures and the knots and everything is to bring everything together. So the tendon is opposed so it can heal. And that's where you're going to get your strength from, isn't it? But there's also a bit of inherent strength in the actual sutures as well.
Yeah, I mean, those sutures should stay strong for,
and I assume they've done lots of studies and they're probably as strong as steel. It's that sort of thing.
The tensile strength of these sutures is incredible. Obviously your knots have got to be good, so there's a technical bit there. But you're relying on that repair holding together, so that you guys then once I clear the patient at 2 weeks, wounds healed, no nerve injury, no deep vein thrombosis, everything's looking kind of settled from a soft tissue perspective, then sutures out and it's over to you guys to start pushing
week
it on.
3, week 4, week 5 with the surgical ones. You can definitely start doing a little bit more, very safely. You can start doing a little bit of just seated calf raise, whereas you would never do that with a conservative. You would probably week 5, week 6 at the very earliest, because we'd be so concerned with it. And I think it is just that you get that reassurance that everything is together. You've got a bit of inherent strength already from the operation, and then hopefully you can push forward. Do you have any tips for people to prevent infections, wound breakdown?
So from a surgeon's perspective, I've started to use IOBAN, which is a sort of adhesive film that you can put over the skin.
Was it
IOBAN?
As in iodine? It's just an iodine.
And that just stops the suture material when you're tying your knots from actually resting on the patient's skin, because the bugs.
Oh, even when you're doing that.
Yeah, because the bugs. The bugs in wound infection almost always come from the natural bacteria that live on our own skin.
Inside us, or on the
so patients get antibiotics
straight
in
away.
theatre, just as part of a routine, preoperative antibiotic.
Sorry, as a tablet, or you?
No, so when a patient has an anaesthetic,
you then
they
put that
also
through
would get a dose of antibiotics.
So IV antibiotics,
IOBAN for the skin. I always let the tourniquet down before I close. So we do these operations under tourniquet. So i.e. there's something around the thigh, and that stops the bleeding, and that means I can see everything. I can see the little nerves, I can see the little vessels. Absolutely meticulous hemostasis, so cauterizing everything, anything that bleeds, and making sure at the end of the procedure, let the tourniquet down and just wait for 2-3 minutes and just see what happens. If there's any bleeding vessels, then you can deal with that bleeding and make sure that you're leaving the area really quite dry before you then close. And that should in turn reduce hematoma, swelling, and it's the bleeding and hematoma that may cause sort of scar adhesions and things like that. So meticulous hemostasis. There's all this stuff around suture choice that we've discussed, and I think that is a factor. And do you
get people to clean the area, or do you just keep them to stay away from it for 2 weeks? Do they have to change the?
I tend to leave all of my wounds wrapped up for 2 weeks.
Don't let them touch it.
The cleanest dressing that ever goes on that wound is the one that's put on in an operating theatre.
In the sterile environment, yeah.
And nothing that happens after is ever going to be as clean as that.
And if you do get not wound breakdown, but if you do get an infection, do you see it in that first 2 weeks, or could it develop later on?
So weirdly, usually if I see someone at 2 weeks and it's looking good, then I'm really happy. But I have noticed I've had 2 or 3 patients get infections a bit later, sort of 3 to 4 weeks, and I do wonder.
But that's when it's healed. The plasters are off.
Yeah. And I think those patients are the patients who are really reacting to this absorbable suture, and they're getting a really inflammatory reaction, and the wound just breaks down a little bit over, and then there's a portal for the rest for potential entry of bacteria. So it's difficult choosing your suture material, because in an ideal world, you want the suture to melt away and dissolve. You don't want people to have foreign material in their body long term. But at the same time, if that causes real inflammatory reaction, these are the kind of things that.
And if I said to you, you see your patients afterwards, do you find there is a lot of variety in the outcomes? And if so, what's your gut feeling as to why?
I do see variety, and I can honestly say I can't predict who's going to do fantastically well and who's going to be slow and struggle. It doesn't seem to relate to any patient factors. These are all pretty motivated.
They're doing their physio. You can't say, well, you haven't done your physio. Or
they're all kind of athletic people, and sporty athletic people are usually quite driven and motivated and want to get back to their sports. They're usually pretty healthy people, good diets. Smoking, I would say, would be a concern for me around surgery, because there is definite evidence of infection and wound healing problems in smokers. But again, you're not getting that many smokers coming through with those kind of sports injuries. So I find it really hard to predict. And some people have a lot of pain, a lot of stiffness and swelling. And it's sort of pain and swelling really hold people back. And other people it's all very settled. And it
almost just feels easy. They just start heel raising, and it comes. And
in all honesty, you can often tell that 2 week check who's going to fly and who's going to struggle. When you see the patient at 2 weeks and it's all looking nicely healed and nicely settled, and they're not in too much discomfort, they've been quite comfortable. That patient's just going to fly through their rehab. Whereas when someone's inflamed and sore, I guess all of our bodies just react differently to surgery, to injury.
Do you think it is, so if we think about the anatomy of the Achilles, you've got your Achilles, and it's inputted it's got soleus bundles, it's got pits of medial gastroc, lateral gastroc. Do you think we need to start to subgroup these ruptures into different groups? If so, how, or the type of tear? And therefore, should that in any way then dictate how you do the surgical repair? Is there any talk of that in surgery?
I think the area of the tendon that we're operating on is almost always the common tendon. So, I do something called a vulpous gastrocnemius recession, which is a lengthening procedure for gastrocnemius, where we're operating much higher up in the calf and actually operating in the interval between soleus and gastroc, coming in from the side. And you can
in the Achilles?
So above the Achilles. So what you can see at that level is you can see the aponeurosis of soleus, the aponeurosis of gastrocnemius, and actually there comes a point where the two things become fused, and you're in that interval, and you can't get more distal because the two things have come together.
That's interesting.
But that is way above the level that we're operating on for a traumatic
It
Achilles
is, but those Achilles go all the way up.
Yeah.
So on ultrasound, most ruptures go very high. So, I always say it's a long injury.
It is a long injury.
And so I wonder whether there's something in that. I don't know how we'd start looking at that.
I mean, the patient I mentioned who had this sort of flap tear, that flap went right up into gastroc kind of aponeurosis and was really high. So I had to extend that incision and do a sort of core repair for the main part.
And then repair further
and then with that flap sort of rolled back on itself to access the main portion of the tendon. And then at the end, it was almost like a V shape, like a tongue. I sort of just rolled that tongue in and did sort of corner stitches all the way around the tongue. Now, whether that added strength through repair, I don't know. But actually, that was one of the few occasions where there was something actually giving me a bit of a read for what was the correct length.
Did you went to go and find? Did the MRI help you think I need to go up there?
Yeah. But that's a sort of a rarity, I guess.
Let's talk about, because I know this is something that you've done in the past. There was a real tendency, I don't know if it's 10, 15, probably 15 years ago, to stop doing open repairs. And certainly in Europe, and I think in the States, they're still doing a fair bit of this, to do what we would call a percutaneous repair. Do you want to just talk us through how that came about and your experience of it?
Yeah, so I mean, the Achilles is almost the perfect area of the body to think about minimally invasive surgery. So, it's very close to the surface, it's very close to the skin, so actually access is very easy. And it is an area that has got a reputation for poor wound healing. So whenever you're thinking of like accessibility and wound healing, that lends itself to minimally invasive. And I think minimally invasive has a massive role to play now, and is a perfectly reasonable, thing to do. If someone asked me, could I have a minimally invasive repair? Then absolutely. But perhaps I'll just expand on
what it is,
where my sort of anxieties around it.
Do you want to explain what it is?
Yeah. So minimally invasive Achilles repair is when you make a really tiny incision, and then there's the sutures that we discussed. We discussed this sort of crack out. Those sutures are actually passed through the skin, through the paratenon, and then through the tendon. And then there's very clever sort of jigs and
what was it? An Arthrex something?
So the first thing that came out was a sort of Achillon, was called an Achillon system, and I used that I think sort of 2012 to about 2015. So I used that for about 3 years, doing these kind of repairs. The problem with the Achillon system, it was very bulky. It was this sort of blue plastic thing, and it was very bulky. The idea with all of these systems is that you make a small incision, that you get into the paratenon, and then you slide something into the paratenon, almost these sort of tongues into the paratenon. You hope with the tendon sandwiched in between.
Right, yeah.
And then you pass there's then a reciprocal...
But this is done off feel, isn't it? There's no imaging assisting.
No image assisting. So it's based on what I was talking about earlier, the fact that this Achilles is within this sort of tunnel, this fascial tunnel, and therefore if you can get these devices into that tunnel, you can pass them up and down. And in theory, there's ways of doing it. You can get a retractor in or something and actually try and grab a bit of tendon and pull it down and actually see that the tendon is sat between the two prongs of these devices. And then they have a matching prong that is then on the outside of the body. And then they have holes in and guides, and they will then guide your sutures through the skin and through the paratenon into the tendon. And then the idea is that because the prongs are within the paratenon, when you pull those things through, essentially all the sutures come into the tunnel. And so, I mean, they're very well proven devices, the techniques, very well established.
And I suppose they came about, as you say, because you could do it. The whole idea, everything's becoming more minimally invasive, is the idea that you don't have such a big incision, therefore maybe you don't have the wound healing risks, the infection risks.
Yeah, it was to reduce infection.
Yeah.
It was to reduce pain. Smaller incisions, less dissection does reduce pain. But it was, particularly to reduce kind of scarring and adhesions that then tether the tendon to the overlying skin, which is an issue in Achilles surgery. So that was where it
as
came
in the paratine onto the skin.
Yeah, paratine or actual tendon to the skin, and you do see patients with tethered scar, and that can be a source of pain and stiffness, and that you asked earlier, why do people not do so well? Probably if tendon is scarring and tethering to skin, that will definitely cause issues.
And they've done big studies, haven't they, that have essentially said this is just as good as open surgery.
There are some big individual studies, and then there are some meta-analysis which combine those studies. And in effect, in broad terms, there isn't a big difference between minimally invasive and open. The big worry with minimally invasive, I have two worries with it. Number one, the sural nerve. You've got no way of seeing it. And a lot of the sutures are coming in from the lateral side.
It's exactly what I thought when I watched that video. And
they're big needles, and it seems to me almost inevitable that you're going to pass a needle through the sural nerve at some point.
And from scanning a lot, the sural nerve is not always on the same place, and it doesn't cross over at the same place over the Achilles.
Now, interestingly, in the studies, the incidence of sural nerve injury is about 1.5% with either technique.
Oh, interesting.
So open surgery, you can damage the sural nerve. But for me personally, I mean, I suppose I operate around that area quite a lot because I fix a lot of my ankle fractures in that posterolateral approach. So I'm very familiar with sural nerve anatomy.
So you're quite comfortable.
And I'm very comfortable operating near the sural nerve. So I don't mind opening and seeing it.
I always think I'd rather a surgeon just open me up a little bit more, just so they can actually see it.
Just make sure, look after it.
I'm
make
not
sure
bothered
it's
about
okay.
the scar.
And so for me,
so you've come round a bit. We were talking about this. So you started, you're sort of back doing what you were doing.
Yeah.
So was that the main reason that I assume if I ruptured my Achilles today, would probably naturally you'll go down the open route.
Yeah, I do, and it's sural nerve was one of my biggest concerns about the minimally invasive technique. Albeit I acknowledge that the studies suggest that it's not really a big issue. I mean, the other thing is I've done that technique in a cadaveric lab, so on cadaveric limbs, and what was interesting, we did the minimally invasive technique, and then you have the option then of the luxury of being able to open everything up and actually look.
Nice.
And what I found was that all my stitches were in the muscular portion. They weren't actually in the tendon.
So you're more proximal.
Quite proximal and quite deep. Yeah. So on that sort of deep side of the tendon. So I wasn't really getting
not quite the accuracy
good hold and accuracy in the tendon. Now, again, that probably doesn't matter. Because you're still probably detensioning, bringing the suture ends, the tendon ends together
to then heal.
Yeah.
So as long as they're together, they're going to heal.
And stopping them from separating when you do your early loading.
Yeah. And from a rehab point of view, there is no real difference in the protocol, from my understanding. No.
So, I mean, I think the evidence is that minimally invasive is equally as good as open.
Yeah.
You might get slightly less wound problems with minimally invasive. I would worry on the flip side about injury to the sural nerve. And I know that with my open crack-out stitches, I know that the tendon is so strong. The repair is so strong. So I'm therefore really happy with my repaired patients to allow them to really engage with physio and push along. So I think it's the reason I've sort of gone from open to MIS and then back to open again.
Yeah.
With just around those sort of small concerns.
Yeah.
But you know,
And also, surely to a certain element, if it ain't broke, don't fix it. I.e., you're getting good outcomes, but people evolve, things evolve, don't they? Who knows? If you start getting a couple of whatever problems, then you're going to start looking at other options again, which is what we should do as clinicians, isn't it?
You always have to, you know, you have to balance this sort of innovating and doing new things. But there has to be a demonstrable advantage of the new technique. You know, it has to be
Some things just become trendy though for no reason.
Yeah.
And I think that became trendy for a reason that it didn't really need to fix.
Yeah.
It just needed to fix the infection thing. But maybe that was because of the sutures or other reasons other than the fact that it was, you know, just an open.
Yeah, I mean, you know, that technique was developed with the best of intentions and to address a genuine problem, which was, you know, wound problems.
Yeah.
So it came from a good place.
Yeah.
And I know, you know, some of my colleagues at Fortius use MIS as their go-to repair, and they've been doing it for years and have and have great outcomes. So I think, you know, to be honest, like as with all these things, you know, if your surgeon is very familiar and very well practiced with their technique and it works very well in their hands,
Let them do
that's
it.
You know, that's the best thing to do. You know, I've done both. I sort of default to open. If I have a patient who's particularly interested in MIS, then you know, that's fine. And I've had that conversation with people recently. When I present and I explain about the operation, generally people go, "Oh, do you know what? I'm not so worried about the scar." And most people have been happy to go with the open technique, but you know, every now and again, we're doing a minimally invasive one.
Perfect. I think the other thing from a rehab point of view is, you know, and I can say this after 25 years, is you've got to see a physio as well that sees a lot of ruptures, because I do think physios, I think a good physio who's seen a lot will often hold people back when required and then often push people when required. And it's that's an art, I think. Completely. It's exactly what you were saying. And I see loads of ruptures and we see them coming into the clinic and sometimes they're like limping in and we're like, you know, and sometimes they're sort of bouncing in and you just straight away get that feel about how hard you can push these. And then there's just a time element where you've just got to respect that tendons take a very, very long time. So I've got a final question for you, and I hope this doesn't happen to you. So you're walking home tonight, you trip over your curb, you think somebody's shot you in the back of the leg, but actually you've ruptured Achilles. Would you opt for surgical or conservative approaches?
God, I'm in my mid-40s now. My rugby days are behind me. I ski and golf. Those are my two big things. I don't know. I'm right at that crossover point. You know, I'm right at that crossover point where I can probably cope without explosive. I was 2 years ago. I was playing squash. I kind of not playing the squash anymore.
But it might be a different answer if you were.
So I would probably cope with conservative management now. If I had conservative management, what I'd make sure is that I'm being seen regularly by, you know, either experienced physio and or a colleague. And just getting that clinical assessment of am I stretching out or is my tension right? And I think if there's any hint, like literally any hint in that first 2 or 3 weeks of stretching out, elongating, loss of tension, I would not hesitate to have surgery.
And I've answered this before in a podcast, but that is my answer as well. Is I would go for a conservative approach, unless, you know, like if there's any sign of elongation, I would go for surgery. I would personally have an open approach because I just want you to see everything you need to see to do what you need to do. And the other thing I would do is I would definitely get an ultrasound scan at 4 weeks. I am not sitting there for another month in a boot not knowing if that Achilles isn't together. So that's the only thing I would add to that. That was brilliant, Roland. I don't know if we've got all the answers yet, but we've certainly talked about a lot of things. So thank you very much for joining us.
I wish we had all the answers, but none of these topics in foot and ankle surgery and orthopedics do we have everything solved.
And don't trust anybody that thinks they've got all the answers.
Absolutely not.
Brilliant.
All right, thank you.